is another episode of my series of interviews with Lindsay Doak, the lead researcher for Berry Dunn, who is telling us little by little as we go through these episodes about the National Healthcare at Home Best Practices Study. Lindsay, welcome back.
Thank you so much, Tim.
Last few times we have talked about staffing and we have talked about best practices for hospice. And so today I want to find out what you have been learning from the study about best practices for home health itself. Where do you want to start?
Yeah. Well, last week we touched on the hospice best practices, and obviously the payment model is different for hospice. So for home health, we touched on a couple of things for the best practices. The first is what makes organizations more successful with the PDGM model and in reducing costs. So those will address the money aspect of home health. And then what are the things that organizations are doing that help improve quality of patient care and patient satisfaction and reduce rehospitalization? Because historically, we've always focused on patient satisfaction and quality of care, but there hasn't been any sort of reimbursement tied to that necessarily. But with value-based purchasing happening next year, we will see different payment structures happening. So we really wanted to focus on that as well. So we started, of course, if you go back to the staffing discussion, I have to preface this by saying we started with you have to have your RN positions filled to do any of these things we're about to talk about. So back when we talked to staffing, we had mentioned that you have to have less than 10% of your RN positions unfilled. So that's the assumption we're going to make at the start of this presentation. What we go back to, there were a few data points within every aspect of the study when we analyzed it, and we looked everywhere. We'd always go back to those case manager caseloads. And we talked about last week in hospice, making sure that those case manager caseloads and then balancing them out with the social worker caseloads. For home health, what we had discovered, and I know we touched on this a little bit, is that you cannot go above 25. So again, you have to have the staff to do this, but making sure that you have those case manager caseloads below 25. There are some best practice organizations that had 19 or less and some that 20 to 25. But in doing so, you are seeing a diminished return on your quality and your patient satisfaction when you go above 25, but also your bottom line. And you say, I wonder why, what's going on there? And so when you take a dive into it, there's a lot of reasons that we can talk about. One is utilization. So if you have caseloads of 25 or less, it feels like you're really emphasizing utilization, and that clinician can see the patient every day. So you're not sending out a different clinician and having any sort of wasted visits. So that's saving you money as well. The other thing too is that we saw that organizations that have case manager caseloads of less than 25 had good outcomes. But when you marry that with organizations that also use an admission nurse model, so we asked organizations, do you use an admission nurse model? When you marry the two, it's even more powerful. So organizations that have case manager caseloads of less than 25, they have 4-star ratings. Organizations that have case manager caseloads of less than 25 and use an admission nurse model have 5-star ratings on average. So increase in star ratings, but they also had the most in terms of the surplus. So PDGM surplus at the bottom. So it's, of course, it's a story that you tell. And so you start to take a look at that and you start to think, why the surplus? Well, then that gets to the PDGM accuracy. So when you use that admission case model, you're really training a seasoned group of individuals to admit the patient. And we know that with PDGM, accuracy of capturing that information at the start is what's going to impact your payment. So we see that organizations that use that admission nurse model have more accuracy at the beginning. They're more likely to document in the home. So again, the accuracy is all happening with that admission case model. And it's not just impacting their quality and patient satisfaction in a good way, but it's also impacting their bottom line. So it was interesting to see how those two metrics came together. And really, I mean, those two together are so powerful in quality, patient satisfaction, and the bottom line of the organization.
Yeah, exactly. And I want to make sure that we explore that a little bit more. The common assumption would be that higher productivity and higher caseload is more efficient, and the more patients per clinician means that you can get by with fewer clinicians, and that should have a positive impact on your bottom line. But what you're finding is the opposite of that. You get beyond, and somehow 25 is the magic number. You get beyond that magic number, and your revenue goes down, your patient satisfaction goes down, everything.
For most organizations, you know, there are some organizations that obviously are making some money by increasing those caseloads, but it gets back to that utilization. You know, with PDGM, you're filling out the start of care, and then you're coming up with a care plan that has X utilization. And so any wasted visit, you're going to lose money. It doesn't matter what your productivity for the day is. You can have productivity of 10 per day, and it's an impossible number. But if you're wasting visits based on the PDGM payment model, you're going to lose money. So those organizations that have case manager caseloads of 20 to 25, you got to think about that clinician. You know, that allows the clinician to be able to see all their patients within a week. So they're seeing their patients. You're not sending out another person to go visit the patient and then having that disconnect and possibly a wasted visit. You know, you should be asking yourself every time, can you keep the visits consistent with the clinician, and is there a reason for this visit? And so that utilization is tied to that case manager caseload. So higher doesn't necessarily mean better if there's a lot of waste that goes around that as well. So it's making sure that you're staying in those healthy ranges so that you're not having those wasted visits.
Now, you also mentioned accuracy, and we have always known a couple of things. Decreased accuracy relates to decreased revenue, and always has. And we've always talked about how the solution to that is training. You want more expertise and knowledge among your entire clinician staff, of course, but especially the ones that are doing the assessments. But you're saying it's not just training, it's also volume and caseload and the use of the specialist doing the OASIS assessments. You're saying that is what affects patient satisfaction, employee satisfaction, and revenue.
Well, I don't want to discredit the importance of education. Like, education is the critical component to all of these things. We have to have education. I think what's happening with the admission nurse model is that we're really able to educate everybody in your organization should be knowledgeable and educated in OASIS and completion of OASIS and care of the patient and PDGM. You know, again, it goes back to making sure that knowledge trickles down. I know I've had organizations reach out to me and say, you know, should my therapist participate in OASIS training? Absolutely. We should all know what that means, why we fill out the OASIS assessment, what it means to have, you know, an accurate OASIS assessment, which is about money, but also making sure that the patient receives the care that they should receive to get better. And then that helps everybody work towards a unified goal of that patient and taking care of that patient. But what we've seen with the study overwhelmingly is that those who use that admission nurse model, so you have dedicated resources for completing those start of care visits or resumption of care visits, have higher outcomes. And so that would tell me that even though broad education is definitely needed by organizations, by targeting very intense education on these admission nurses. Obviously, you're not going to send an admission nurse out if they don't know what they're doing. Hopefully, no organization is doing that. They're really providing them with intense education. They're testing them, so making sure that you're testing them and their ability and their knowledge, because testing was a big part of the study. And everybody said with the higher quality scores said that they test their clinicians. They're modeling them, they're following them. But by training this targeted group of individuals to do these start of cares and making sure that they are documenting in the home is resulting in better outcomes, better reimbursement, and I think it's just more sustainable. So to have that group of people, that smaller group of admission nurses versus trying to get everybody at that level. And that's difficult. Everybody should know about OASIS, but everybody at a really high level of OASIS and completing that start of care and documenting is harder to achieve.
And that brings up a couple of questions. You mentioned documenting in the home. Did you include that question in your survey about whether that is required or encouraged or not?
No, we asked in the study what percentage of your clinicians document in the home, or what percentage of times do your clinicians document in the home? And so that was broken down into categories. So it was like 0 to 25%, 25 to 50, 75, 50 to 75, and 75 to 100. And of course, we didn't get many people responding with the 75 to 100 because that's a very wonderful goal to try to achieve, but very hard to sustain. But what we saw was that organizations that had, it's the story, right? So had caseloads of less than 25 and then had that admission nurse model were more likely to document in the home. So they had the majority of those organizations, 50 to 75% was their answer. So 50 to 75% of their clinicians document in the home. Organizations that didn't do that or reported, that they documented 0 to 25 or 25 to 50 had lower outcomes. So we've always known that documenting in the home is key for an accurate assessment. For every hour that you wait to document on a patient, even in the driveway, you're done and you go to the driveway to document, decreases the accuracy of the documentation. And we all know that the documentation is critical. Yeah.
Clinicians are human, and humans have memory, and memories fail, and they decrease minute by minute between the moment you leave the patient and the end of the day. So accuracy obviously is going to be at a higher level when you're completing your assessment in the presence of the patient.
Absolutely. And that's what we've always tried to achieve, have documenting, completing that. And there are ways to do that in the home with the patient, because the concern with organizations is if I'm documenting, then the patient's not going to be happy because I'm sitting there typing at my computer. So the patient satisfaction is going to go down. So I think that's a lot of the times the thought that we shouldn't be doing too much of that because that's going to diminish patient satisfaction results. But having talked to organizations and provided training in this, there are ways to communicate that with the patient so that they understand why you're spending that time documenting in the home. There's verbiage and scripting. So also incorporating that into your organization and making sure that they're communicating with that, because you don't want to just say, okay, document in the home, and now you see your patient satisfaction diminish. So you have to have all the pieces put together, and you have to have your clinicians able to articulate to the patients why they're doing what they're doing, taking appropriate breaks. And it's a fine balance, but we got a lot of things to juggle with patient satisfaction, quality, reimbursement, but there are ways of making sure that that's all done successfully.
Some of the people that I have spoken to over the years that have the best outcomes have talked about including within their training the concept of engaging the patient while you're documenting, explaining what you're writing down, why you're writing it down, and that should be a part of all OASIS training.
Yeah, that's one of the ways, and talking about the importance of why you're doing what you're doing, but also that engagement. So not having it be a moment of silence, but rather a dialogue between the clinician and the patient as they're documenting.
The other thing that comes to mind is ever since the introduction of PDGM, coding and code sequencing has become a lot more important than it was in the past. Did you ask in the survey about the use of in-house or third-party coding services to increase the level of expertise in that part of the process?
We did. So we asked organizations if they conducted their coding internally or outsourced. And then whether they use clinician or non-clinician coders to do any portion, internal or outsourced. And what we found was that the majority of centers of excellence outsource their coding. There's been a shift in the industry to where if you'd asked this question 10 years ago, nobody would have been outsourcing their coding. And there's been a major shift to outsourcing. And I think there's a lot of reasons why these centers of excellence are doing that. Well, first of all, is for accuracy, as you had stated. It's hard to keep people up to date on the code sequencing, and it is very important with PDGM. But also in outsourcing, as we talked about with the staffing discussion that we had, it's hard to find people. We can't find people to even fill the RN positions. So by outsourcing some of that, you're then able to focus on really hiring the people that you can't outsource. So finding those field clinicians and focusing on the training of those field clinicians. So it kind of takes that off their plate, making sure that you find a reputable vendor that has accuracy and auditing processes in place, but we're seeing that shift. So most of these centers of excellence are not managing that, and it's improving their outcomes because of the training, but also I think because they're able to focus on the delivery of care to the patient.
So what would be the bottom line? You're talking here about patient satisfaction and maximizing revenue to the extent the law would recommend or permit. So can you give us what would it be? Give us an overview of a ideal agency and the kind of practices that they have deployed, the ones that put them into the top performers in the top 20% that you talk about.
Well, it's a combination of things. So it starts with the case manager caseloads, and then the admission nurse model. And then we're taking a look at, again, organizations that are paying attention to what is happening in their organization. So it's funny when you look at the question, how do you monitor your star ratings and what do you use to monitor your star ratings? And, we had EMR, third-party vendor, and we don't monitor our star ratings. And then for EMR and third-party vendor, the average star rating was about a 4.5 for quality. And then those people that said they don't monitor their star rating, their average star rating was a 2. So
Wow.
talking to these organizations, it goes back to paying attention, using the data. And then when something goes wrong, following up on that. If you have a patient that's rehospitalized, follow up. Why were they rehospitalized? Have a team meeting, talk about what went wrong and how you could fix that. So that's a big part of it. Using this data, technology is difficult, and I know we'll have a separate technology discussion. I think that there's a lot of technologies out there, right? And we haven't mastered how to use all of them. And there's been some resistance to adopt some of the technology. But one of the technologies that is critical are those data technologies, those that provide you with the data to make executive decisions for your organization. So benchmarking tools and those types of things. Critical that you're aware of what's going on in your organization. And when something goes wrong, you meet and then fix it. And then, you go back to the revenue side, and we talked a little bit about this earlier, but productivity is a key metric. And I used to be one where I would say you shouldn't worry about productivity. It's all about care of the patient, because it really is. It's about delivering the appropriate care for the patient when they're in the home. But what changed my mind was that when I looked at the study data, those organizations that said they didn't monitor productivity, and it was like 20% of organizations said they didn't monitor productivity, actually had the lowest outcomes. And so that would tell me that you need to be monitoring these things, right? It's not going to be 100%. If you say your productivity measurements are 5 a day, you're never going to meet that measurement at 5 every single time. There's going to be things that happen in the home that you have to address. We always say 70% of the time you should be trying to hit these metrics. But by monitoring the metrics, having metrics that your staff know are metrics for success, and then working together to achieve these goals, I think unites everybody and helps them then they know what their goals are. They know what their measurements of success are, and it helps everybody come together and provide success for the organization.
It's
But
the
then
old
taking,
adage, you can only measure, you can only improve what you measure.
exactly. And productivity is a difficult one. I know that it's controversial in some organizations, but having that out there and knowing that there's some flexibility, I think gives people an understanding of what our goals are and what we're trying to accomplish.
In one of our earlier episodes, when we focused on staffing, you did mention different payment models. And I wonder if you could explore that with us now. In addition to productivity, you have found a difference in outcomes based on how clinicians are paid?
Yes. So going back to productivity, what we discovered was that, you would think that lower productivity would result in higher quality outcomes because the clinician is spending more time in the home if they're only, but what we discovered was, those with 4 or less had similar quality outcomes to those with 5 to 5.5 visits per day. But the patient satisfaction was a full star lower. So 3 stars versus 4 stars for those with the 5 to 5.5 measurements per day. And then the other thing we discovered is you don't want to go over 5.5 visits per day. It ends up being a direct nursing cost per visit for 5 to 5.5 is $88, and then over 5.5 is $86. And the diminished returns of your quality and your patient satisfaction are not worth that $2. So don't go over 5.5, but then take a look at that 4. And then when we dove deeper into that 4-star, that 4 productivity number and why they had lower patient satisfaction, what we discovered was that those organizations that had productivity standards of 4 were more likely to have nurses self-schedule routine visits. And so those organizations that had nurses self-schedule routine visits had much lower patient satisfaction, significantly lower patient satisfaction scores than those who used a dedicated scheduling team. And so it was that metric that was bringing that patient satisfaction down for that productivity. So when nurses are scheduling, it seems they're not being as productive and their patient satisfaction is being diminished based on the data. Now, we're not saying that nurses should not schedule routine visits because there's some bit of autonomy and employee engagement that comes with that. But to have a centralized process, to have clear scripting, making sure we know that the number one thing that patients dislike is when you cancel their appointments, when you're late for their appointments, or when you send somebody different than what they expected to come. I mean, those 3 things right there are everything to the patient. And so if you have some centralized process so that if you have to cancel, if you have to be late, if you have to send somebody different, there's communication that's happening to the patient, making sure that they're aware of what's going on. There's a script to help them understand why, to talk them through it. Those are the types of things that a centralized process and training in that area is going to help so that when those things do happen, that it's not going to impact your patient satisfaction.
Did
And
you
then
also find, oh, go ahead.
and then for pay, what we had discovered was that for payment models, we had as a steering committee, I remember the meeting where we all sat together and we were talking about what's your payment model. And then 2 of the steering committee members said that clearly those who have per visit per DM are going to have lower quality scores because it's that old adage, if you get paid per widget, for finding an error in each widget, you're going to find more errors, right? So you're going to quickly get through your visits, and you're not going to care about quality and patient satisfaction because you're going to not care because you're just getting paid per visit. And what we actually discovered was that clinicians who get paid per visit per DM had the highest quality and patient satisfaction scores. So I'm not saying that this is the perfect payment model for everybody, because I think there are some organizations that pay salary that also achieve good quality and patient satisfaction. But what we aren't seeing is diminished quality and patient satisfaction just because you're paying per visit per DM. They are taking the time to spend the quality, and there's not any sort of, if there are organizations that are thinking of not moving to that because they're afraid of diminished quality and patient satisfaction, our study data would tell us that would not be a worry that organizations would need to worry about.
Well, Lindsay, you have given the home health owners and administrators and all of the management team a great deal to think about. I would imagine that because you got a range of answers all across the board, that there are hundreds, perhaps thousands of home health agencies out there that have all different levels of practice, all different policies. And knowing now what works better and what doesn't, I'm hoping that this whole study and your exposition of it is helping people to understand ways to improve, because things are certainly not going to get easier and better with the
Wow.
value-based purchasing coming, and the way that the payers like to try to push us down into lower and lower payment levels every year. Finding ways to improve both quality, satisfaction, and revenue is going to not just be a matter of pride, but a matter of survival.
No, 100, and that's why we did this study. And, there, I think we said on the last call, but not today, there are 781 agency sites who participated in the home health study. So we had a good sample to take. It wasn't 5 organizations that filled out the survey, it was 781, to really figure out what are the best practices, and then wrapping that up and handing it to home health agencies, because we recognize it's going to be a struggle. And if organizations can take 1 or 2 of these metrics and implement and make changes, either improving their outcomes and helping them succeed with value-based purchasing, or improving their bottom line to potentially deal with these cuts that we may see. We want these organizations to succeed. So we're giving them the data to help them to get there.
Well, based on the feedback that I've gotten from our first 3 episodes, this has been extremely helpful to people, and we are going to continue. You mentioned technology, and I'm hoping that maybe in the next episode, since that's my area of interest, we can focus a little bit on what you learned about what technologies people are using, what seems to help, what seems to hinder. So if that's a teaser for next time, maybe that will encourage people
we
to
won't say
continue
for
to
sure.
this.
We need people to log in, but it could be technology next time. I will say that.
All right, that's close enough to a promise for me. Lindsay, thank you once again. For those of you who might have enjoyed this episode but found us for the first time, on the final slide today, in addition to putting the link to the entire survey so that you can read it if you like, I'm also going to place the links to the previous 3 episodes to make it easier for you in case you missed those. And I've also published the links in Home Care Tech, the Rowan report, every issue when it comes out. So be watching for that. If you're not already subscribed, it's easy to do at homecaretechreport.com. And the topic today is available in these episodes, in these recorded videos, as well as on the Berry Doak website. So Lindsay Doak, Berry Doak, right? That didn't mean to say it that way. Lindsay Doak, the Berry Dunn lead researcher for the National Healthcare at Home Best Practices Study. Thank you once again for joining us. This has been enlightening, and I look forward to the next one.
Thank you.